Hi, my name is Cheryl. This is my presentation on pulmonary hypertension. I'm going to just pretend like we're in a classroom and I'm recording this on YouTube. So I'm just going to walk you guys through my presentation. I hope you enjoy it. So what is pulmonary hypertension? Pulmonary hypertension occurs when a narrowing of the blood vessels in the lungs causes the right side of the heart to work harder. Let's do a quick anatomy review because I know that some of us learned this way back in the day. So here's our heart. We have deoxygenated blood that comes in. That's the blue part. It's already done its thing in the body. It goes from the right atrium into the right ventricle and then out through the pulmonary arteries into the lungs. So that's the important part and the main location that we're talking about here in this disease process is the pulmonary vasculature from the pulmonary arteries. So the blood flow, again, it's going down and out into the lungs. So what is the problem? So normally blood flow from the right side of the heart to the pulmonary arteries is low flow, low pressure, and high volume. It's a fairly effortless process and effortlessly goes through. But the problem occurs when there's a narrowing of those pulmonary arteries, and that impedes the blood flow. The right side of the heart has to work so much harder in order to get the same amount of blood into the lungs and to the rest of the body, and back to the heart and to the rest of the body. That is not so effortless. As we will see, it gets stuck, kind of. So what causes the narrowing of the pulmonary arteries? There are 5 different classifications of pulmonary hypertension based on their etiology or causes, and we'll look at those here in a sec. The first group is the pulmonary arterial hypertension. This sometimes can be used as a broad overterm. Sometimes you'll hear people say PAH, and they're talking about all of it, but it actually is group 1. They're idiopathic etiologies, drug or toxin-induced. Methamphetamines and cocaines can cause this. There's some other drugs as well. And connective tissue disorders, there's a whole list. These are the basic ones. Group 2 is pulmonary hypertension due to the left heart disease. And most of us know what left heart disease is and how that can affect our body. Group 3 is pulmonary hypertension due to lung disease or hypoxia, so states that create chronic hypoxia like obstructive sleep apnea, COPD, asthma, different lung diseases. Group 4, pulmonary hypertension due to pulmonary artery obstructions. These are things like chronic pulmonary embolism and different obstructive that will actually obstruct the flow of going out. And group 5 are things with unclear etiologies or they could be multifactorial. So pathogenesis. So here, remodeling of the pulmonary artery occurs when? Now just for a brief overview, here's your basement membrane, here's the intima, here's the media, and here's the externa. This is what an artery looks like. And I think it's the same for an arteriole. Smooth cells, they multiply, causing the intimal lining here to thicken. That causes the medial layer to enlarge. So now we have this layer is getting bigger. This causes an increase in adventitia and scarring, which causes an inflammatory state that releases vasoconstricting substances. So not only are we thickening, but now the inflammation is causing vasoconstriction, which further narrows those arteries down. And over time, this causes the vessels to lose their ability to expand and contract with normal everyday movement, such as walking up the stairs. Your heart needs to expand and works a little harder and faster. The vessels need to be able to have that high flow, low pressure state, which they do not have in pulmonary hypertension. When pulmonary arteries lose their ability to expand and contract, this leads to increased pulmonary vascular resistance, or PVR. This leads to pulmonary hypertension. Got all that? So, what's the big deal? The right heart enlarges as it works harder, so the body can have the correct amount of oxygenated blood. Eventually, the right heart will get tired and fail. And that's what we see with left-hearted failure too. The heart is pumping and pumping and pumping, and like any muscle, it will get bigger. When it fails, when the right heart fails, body organs and tissues don't get enough oxygen they need, and when that happens, they also begin to fail. This can cause many of the different symptoms that we see with pulmonary hypertension, which is why sometimes it could be 2 or 3 years before a diagnosis of pulmonary hypertension is made, because the symptoms are actually from hypoxemia. Chest pain with activity, shortness of breath, fast heart rate, low blood pressure, edema, anxiety. All of these things can be a cause of many other illnesses, but they can also point to pulmonary hypertension or decompensation of pulmonary hypertension as well. So, pulmonary hypertension is an incurable disease, and it ultimately leads to death. But there is treatment for the symptoms of pulmonary hypertension, and people can still live functional and quality lives. There's a little caveat to that, in that if you remove the offending etiology, for example, if you have a thromboendarterectomy, pulmonary thromboendarterectomy, to remove a clot, and you are able to get to that before all of the changes in the pulmonary vasculature occur, then you can effectively cure pulmonary hypertension, but basically they didn't have it to begin with. Since the cause of pulmonary hypertension is the narrowing of the pulmonary arteries, treatment is aimed at opening them up. I'm a genius. Gotta love Sid. Medical management depends on the etiology. Remember those groups? So this is a little table of some commonly used drugs for pulmonary arterial hypertension, and this is group 1. So these are your some of your idiopathic connective tissue diseases. Some of them can be autoimmune, inflammatory. So if we also want to focus on the anti-inflammatory properties to potentially decrease the thickening of the lining of the arterioles. Other treatments are aimed at managing the underlying illness. Some examples include managing hypoxemia and lung disease, removing obstructions like the pulmonary embolism in thromboendarterectomy. Sometimes a lung transplant is feasible in patients that have advanced stage PH, but they don't have any other underlying conditions or many other underlying conditions. This isn't as common of a treatment. So what does this mean for me as a bedside nurse? So understanding the patient with pulmonary hypertension requires a proactive and multidisciplinary approach. As bedside nurses, we are uniquely positioned to notice vague symptoms of decomposition, which we talked about earlier, such as exertional chest pain, EKG changes, and dyspnea, among others. And like I said, they are so common in so many other illnesses. Our job is to anticipate and prevent the decompensation of pulmonary hypertension. So if we have a patient who's admitted with a history of pulmonary hypertension or right-sided heart failure or we want to be thinking about, well, do they have some of these, do they have exertional chest pain? Is it unstable angina, or is it just something that they kind of always have? Well, this patient has a history of pulmonary hypertension. It could be that they are decompensating because they're critically ill. Just a couple of things to keep in mind as we manage patients with pulmonary hypertension. And of course, keeping in really good communication with our physicians. A lot of times these patients are managed by pulmonary hypertension specialists because it is such a complex disease. And I'm all done. I hope you enjoyed this presentation. It was very challenging and hard to do, but on the flip side, it was fun, and I'm glad that I did it. Here are the references. If you want them, I will leave them up briefly. And I'm out.